possibilities that can provide advanced diagnosis and also therapy. But it's very important when we do this procedure also to prevent, identify, and treat adverse events, because the more complex that the procedures become, the more they can be potentially dangerous. So these are some techniques that we do: sphincterotomy, sphincteroplasty, dilation, resections, cannulations in the bile duct, in the biliary duct, in the pancreatic duct. We can use a guide wire, we can inject, manipulations. These are, for example, during ERCP, some of the adverse events. So you can understand that even for of course, as a physician, but also as a nurse, this is not an occasional job, and expertise is required, because it's in the manipulations, not only from the physician, but also from the assistant, that we can prevent these adverse events, and also reach our therapeutic and diagnostic and therapeutic goal. So this is a bit our agenda for today. We're going to talk about the different tools that we have. We're going to talk about ERCP, US, dilations, therefore guide wires, contrast, use of sphincterotome, extraction balloons, dilation stents. We're going to talk about our vision. We have endoscopy, we have US, we have X-ray, and we have a lot of videos inside that you can see that we will comment. And there's specific parts you can ask questions on them, and the 10 commandments for the end. So we will start with the guide wires, and you see that you have a different guide wires regarding what you want to do, and the more flexible a guide wire is, the more it will be useful to access and go through an anatomical difficult part, to go, for example, in the distal part of the bile duct, or through a stricture. And the more stiff it becomes, the more it's useful to do an exchange. For example, it will be useful for you to put in a stent if you need some tension on the wires. Then it's better to have a stiff wire in this case. And there in the middle, the table that Sonia had prepared, you see that it's the hybrid. It's the stents that the guide wires that can be used. The guide wires that you can use for both access and exchange. And you also have different diameters of the guide wire. This is important to know which device you put it. And then you have long and short use, and the long will help you to have a bit more help. The nurse can give you more help as a physician in the long. You have to be careful with your exchanges with the long system. In the short system, the physicians have a bit more autonomy to do things by their own, but we know that an experienced nurse in this setting cannot be replaced by even a very experienced physician, because 2 hands in this case is better than 1 pair of hands. So we have the torque. The use of the torque is to be able to block your guide wire and change the orientation of the curve, as you see here. And this is on the tip, which is curved. It's hydrophile, it's flexible, and it's radiopaque. So you can see it very well on X-ray. We can see different guide wires in this photo, and this is the tip is flexible. This is the idea of having a guide wire to go through a difficult anatomical situation. This is the torque. And this is also the different possibilities you can use if you don't have a torque. So this cochlear forceps to block, and by blocking it, you can rotate it, and also to make a loop. And with your loop, you block it as well, and you can rotate it. But we can maybe show this also afterwards, hands-on. Huh? Contrast. So we use different syringes regarding the catheter that we use. So remind me, girls, we use
the large one, but usually for the cystostomy, we use smaller syringes.
So it doesn't really depend on the diameter. It depends on the diameter only. Yes.
Precision and the diameter.
Okay, so the procedure just need the diameter. So when we are going to, as if the physician is going to use a device to get into the papilla, he will use a ball tip catheter, which is the tip is radiopaque and it's less traumatic, or the sphincterotome. The sphincterotome, we usually use 3 lumen. The sphincterotome has the bonus of being able to bend it a bit, so you can also have a predetermined orientation to get into the bile duct. And we can also catheterize with an extraction balloon, but of course will not even imagine using that in a native papilla or in a patient with a previous sphincterotomy, because it's for a bigger instrument and it's very stiff. So there's 0% of success in doing that in native papilla. So these are our tips and tricks here. We before going in, we trim the catheters, we prepare them according to the target. If it's in the biliary duct, you can already pre-curve them like this. You make it a bit straight if you want to go to the pancreatic duct, which is more an horizontal towards the right position. We always use a new one if we want it to be straight. For example, if you're doing a biliary of 2, you're coming from underneath and you want it to be not curved at all. But of course, now with accreditation, everything has to be single use. Uh-oh.
Yeah.
Sorry.
Yeah.
We're back. It's back. We use Luer lock syringes so that you don't have a explosion of contrast everywhere. And of course, this is very, very important. You should never over inject. We do a lot of, for cannulation, we do a lot of guide wire cannulation. Sometimes we do inject a bit to see the distal part of the CBD. But of course, this is all the art of injecting, doing small pulses just to see a little bit of the contrast. And also when you do a hilum and you have intrahepatic bile ducts with strictures, you're not going to inject everything because you have to drain afterwards. So you will try to see the MRI beforehand, decide with your team what you're going to treat, to put the stent, for example, and then you will inject that one and then you will drain afterwards. So there's different injection types, as I said. So it's always careful, of course, but it can be with little short movements if you're searching for the duct. If you're inside the bile duct and you want to inject to fill it to see, then you're still careful, of course, but you have a maintain injection to fill in the bile duct. And then if you want to see if there is a leak, then it has to be more rapid and with some air bubbles just to see a passage. For example, if you're searching for a leak after the cystic duct after cholecystectomy. So the sphincterotomes, we have now mostly 3 lumen sphincterotomes, the standard ones that can help. You can work with the guide wire in place and also the contrast ready to be injected if necessary. So this is very good hybrid tool. We have smaller sphincterotomes. They have only 2 lumens, but they are very useful if you have a very small papilla or in children. And in this, we have also to take care that that's not the same guide wire that can go in all the sphincterotomes. The minitome will take maybe a 20 inch guide wire, 0.020 guide wire, not the larger ones. And then the pre-cut needles, this is if you want to do a pre-cut, again with 2 or 3 lumens. This is what I explained this morning in the hands-on for the young doctors, that it's very important to look at the papilla, to examine the papilla, to identify all the structures, because these are the landmarks. These are structures that are going to help you as well to follow the procedure and to help also. If it's a young physician, you have a very big responsibility as well in the procedure, because it's mostly the nurse at the beginning that tells us what to do. So it's important to recognize its anatomy. We will use current to cut. Usually we'll use blended, only in pure pancreatic. We might use only pure, but blended for all the biliary sphincterotomies to avoid the bleeding. And if there is a bleeding, you can go to cut, to coagulation only, and then back to the blended. And I explained this also this morning. We had the possibility to do sphincterotomy on the model. We really go very progressively by seeing the wire and cutting while watching, aspirating a bit if there's any smoke, step by step. For the biliary sphincterotomy, it's 11 o'clock, and until we've done a complete sphincterotomy by following our landmarks. We also consider, as I said, landmarks and the duct diameter. Sometimes if we don't do a full sphincterotomy, we can also do a dilation with the balloon afterwards to have the full access to do what we want to do, put a stent, take out the stone, etc. So tips, we can pre-bend the sphincterotome, prepare it. If you want to go in the biliary, you prepare it a bit. You can, when the sphincterotome is out, we can rotate it, and we tried the microtech sphincterotome today. We can rotate it in the direction you want a bit, to be, if it's a bit like this, just pushing it about 2 or 3 millimeters on the right might help. And as I said, the minitome, this is a small sphincterotome. It's only 2 lumens, so you can either inject that or use a 20 guide wire, but it can really save us from difficult cannulation. It's what we use in patients and children, and when we do a sphincterotomy of the minor papilla. So this is the first video with the different guide wires, and this is how it's mounted. You see the tip, which is not a straight tip here, and the end is flexible. It's friendly with water, and you see clearly the difference between the tip and most of the guide wires have a very stiff body, but the tip is very flexible, as you see here. So you can imagine it can go easily to search the way in. Hmm? Ouais. The stiffness.
Yeah.
So this is you see that the guide wire is inside the sphincterotome, and when you change it, you see the different degrees of orientation that we can do. It's not on off, as Sonia is saying, that it's not boom boom. So you really have to control your movement. I want it to be a lot bended. I want it to be a little bit bended. So you really can do that with the sphincterotome and progressively find your best direction. This is the torque. Then you see, by using the torque, you can change the direction of the tip. Does of course make sense to use a straight guide wire for this. So this is a very nice example about for all instruments about the looping. So looping is nice because we'll see afterwards, very important to have everything tidy. But if you see, when you have loops, the force transmission is not so good. The force transmission is better when there are no loops. So that's why we see you all going like this. This is something that not everybody knows, but when a doctor does the biopsy, forceps, it doesn't work, because you know that you have to take out the loops. And we can see very well here that there's a different transmission of forces. This is also important for the snares and all these devices. So extraction balloons, this is again we're talking about stones in the bile duct. So here we see all the possibilities of what you can do with your hands and your belly, yeah. Correct, huh? Mm-hmm. Yes. So you have to manage the guide wire, you have to manage your contrast injection, and you have to manage your balloon inflation. And which one do you put to your belly? The
Depends what we want.
depends what you want.
Usually the balloon inflates.
So the balloon inflation is usually in the belly, but you have to
put the guide wire and you want the injection when you come out.
Yes,
When you
yes.
use the belly.
You adapt the balloon,
Yes.
you inject the contrast, and you push a wire. So you
Use the belly. Yes.
normally you need 3 hands, but
Or belly.
or the belly. Yeah, you're working on the belly. So we have different extraction balloons, 2 lumen and 3 lumen. Again, the 3 lumen, as you see in the fixtures underneath, different sizes according to your CBD diameter, according to your to the stone size as well. So you flush with contrast already to avoid putting bubbles inside your bile duct, because it's sometimes difficult to differentiate between an air bubble and a stone. First you inject, and then you to get rid of the bubbles that will go around, and then you inflate the balloon to have your cholangiogram at the end. You inflate according to the duct diameter. You will adapt also according to the duct diameter. So when you come back, if there's a stricture, you will decrease this. You adapt, and this is very important when you bring down your balloon and you're out you've done the extraction. You have to quickly deflate, because if you keep it inflated, then you lose the guide wire. And if you're out, of course, you avoid pushing it. So it's a very important transition phase where you just deflate and you wait till your doctor is ready again to go up in. So of course we have also the devices like Dormia, the mechanical lithotripsy. We have the extracorporeal lithotripsy and cholangioscopy with laser or EHL to break stones. But the balloon is maybe the first step technique. Also very good for young doctors, because there's no risk of blocking the Dormia, the balloon inside the CBD, as with the Dormia. So dilations, this is also enteral, but also duct, bile duct. We have different type of dilations, but mostly it's balloons on the right and the bougies on the left. And we also have the achalasia balloons. That's it's for other indications, definitely not for the bile duct, but for the cardia or for the sleeve, the body of the sleeve, we can inflate with air, 30, 35, rarely 40. We have balloon dilations for ERCP and enteral. The principle is the same, but we use a small manometer for the small ERCP balloons, a large manometer for the enteral dilation balloons. We fill 50-50 contrast saline, and we have to put the stricture in the middle, the middle of the balloon, not to put not too much liquid, and you have to guide a bit the physician as well, so you can both be coordinate. Because if you inflate too quickly, then he might be exposed either above, either in this below the stricture. So he has to stay in the middle so you can get your balloon dilated. The bougies are progressive structures that with a marker that you can use in the bile ducts, or also in the for enteral strictures with different diameters, as you see here. The Soendra is a very interesting device. You need some experience to use it. It's kind of like a screw, which is with different diameters as well, and it can go on a guide wire. It was initially used to take out stents, but we use it now mostly to screw our way through very, very fibrous strictures. We don't like those that have a step, but the most that are more progressive. And this can be used in patients with chronic pancreatitis that have a lot of stones and very fibrous strictures. And of course, the cystotome, this is a bit advanced We could use it if there's like a lot of hyperplasia in a uncovered stent, for example, and you will use a current to go through electrocoagulation. You can see the settings here. The extraction balloon is not a balloon for dilation, and you can see the differences. A round ball, which is for extraction, and the oval, like the rugby balloon, is for dilation. So we have a small video. So this is the importance of seeing the X-ray before. So here you see lots of stones there up, that's in the gallbladder, then a stone there in the middle. So that's a radio-opaque CBD stone. This patient had cholangitis, so was pus already coming out. Here we cannulate with the sphincterotome. We see the direction, we are towards 11 o'clock. We inject and we see the stone. And so here we put the guide wire in, and we will do the deep cannulation. So this is another important thing. The guide wire might go in the cystic duct, as you see here. So it's very important to try to get the CBD. So you will come back with the guide wire and change a bit the direction with a small wheel, ask your physician, and to try to push the guide wire in. Here we did the sphincterotomy. This is the exchange. So we will leave the guide wire in place, elevator, come down with the balloon on the guide wire. And we will inflate above the stricture, above the stone. And we bring it back by the doctor pulling the balloon downwards until this is our video with Sonia we did, until we reach at the end where you cannot pull it anymore distally. He blocks the balloon catheter, and then we bring the balloon out, but in the direction of the bile duct. So by retracting the tip from the papilla, big wheel up, and pushing the scope downwards and giving it a bit clockwise torque to go in the direction of the bile duct and to bring the stone in this axial, in the same axis. So this is the maneuver for the extraction. And here you will see that we have to deflate. Here we didn't deflate quick enough, and then we lost the guide wire. So we'll have to cannulate again, which he has a sphincterotomy here, so it's okay. But it's very important to follow the movement to deflate. The stone is out, the one that we saw. We can recognize the form of it, and then we have our balloon occluded colloidal to confirm that there's no more stones, and to have a good look at the anatomy of the cystic duct, if it's first third, second third, superior third of implantation. This is very important for the surgeon. Okay, this is a mechanical lithotripsy. So this is, yeah, you see it and you forget it. You see it and you forget it. So this is how you prepare the handle. So you unlock by turning the knob counterclockwise. You open the ratchet. You put it on off, the ratchet. And then you will mount this is a dormia. So we put in the sheath, we bring it in until you see the black marking. So the whole basket is inside the plastic sheath. This means that you can see the black mark, so it can be assembled. Yellow, yellow. So now you put the stem inside the handle. You turn a bit the knock clockwise. And you have the markings, the yellow marking, as Sonia says, to align them. And this is well aligned. This is the injection port near these yellow markers, which you can flush. So this is how the basket is introduced. You have the sheath, and you have this metal sheath outside that will crush the stone. So this is how you open the basket. You can rotate it to catch the stone. Just that with the tip that you do this. You see that you can turn it. When you have your stone, then you're going to retract the plastic stem, the plastic sheath by keeping your basket open. So it's metal to metal. So the arms of the basket and the metal sheet are in contact. And then you will, when you're ready to crush, you put it on, it was off. And then you will turn the handle and crush the stone. And you can do this open again, release. So this is our demo. This is how you move your basket. This is our nurse eating chocolate, Sergio eating the chocolate. So this is, you retract the plastic sheet with, wait, no, yes, you advance the metal sheet as Sonia tells me, then you put the ratchet on and you crush. And we again bring back the metal parts to repeat the maneuver if necessary. It have been so easily to put the stones like that inside in real life. There, when you catch it, you advance this metal sheath, put on, and you crush again. And then we can bring it back again and repeat. And we also have a real case in the oui. So now we're advancing the metal sheath over the plastic sheath. You lock it there. And you put it,
Yes.
yeah. Then on. And then we crush. I might end up learning this finally by seeing 3 times the video. It's very difficult. And you have your port to inject saline if necessary. Okay. So this is an example of esophageal balloon dilation. So we, as we said, we have manometers, the smaller ones for the small balloons on the left hand and the larger ones for the larger balloons. Here it's an esophageal stricture, so we're using the larger ones. You have the directions to deflate, as you see here, and inflate. This is the X-ray, we see the esophageal stricture. So we prepare it, half contrast, half water. This is to inflate and deflate the balloon, and you will see the manometer, and you will adapt to the instructions of the balloon, of the device, and the millimeters you want to go. So for example, 18 millimeters, you want to go, it's 3 atmospheres, and then you'll add in pressure to go to the 3 diameters. So you have a lumen with the guide wire. And the balloon, to inflate the balloon it's noted balloon and it's on the other side. And you have your instructions also on your balloon. So when we're in place, you can see the balloon on the screen. The same idea that you try to stay in the middle to be efficient and not to slip above or below the stricture. Here we'll push the guide wire through the stricture and this patient, but here it's not a complicated stricture, short, and we don't, it's easy to go through. But if you have to find the stricture before, you can use also another guide wire. Then we connect the manometer to the balloon lumen and we will inflate. So we're in the direction of inflation. So you always have your instructions there nearby, and you follow your the inflation. And here is where we're going to also see if there's stability and the needle. If the needle does not, if you're still dilating with your pressure, your needle will go down every time. So you have to put again some pressure. So when we reach the maximum, we will ask, are you stable? Is your needle stable? No, it's still dilating, so we still wait. We can see also the image of the stricture through the balloon if you put a little bit of water in position really on the balloon tip. And also you have your X-ray for that. And then once we have finished, we'll deflate by changing the switch in the other direction, using the handle again, bringing a bit down so it can deflate easier. And we have to wait till it's quite deflated to take it out through the scope, because it's sometimes the big balloons are a bit chunky. And also you can use the balloon in front after a little bit of deflation to pass through the stricture, as we call the small tray. The petit train, the small tray, the little tray. So the different stents that we have, plastic stents. So you see in the duodenal lumen on the right hand, we have pigtails, we have the ones with the flaps, single pigtails, lots of different models, and also difference in the duct part. If you need, if you have another flap in the duct, or if you don't a flap in the duct for the last stent, as you see here, this is used for prophylactic stenting of the pancreas. We want the stent to migrate at the end. We can put stents in parallel, multiple stenting. Most of them, apart from the small ones, the small diameter ones, are inserted with a pusher and inner catheter. We can use it either in long if we put one stent, or in fusion with its, if we two or more. This will help us to keep the guide wire inside. We have a video with that afterwards, to keep the guide wire inside once we put the first stent, and then continue putting them next to the first one. And to retrieve the stents, we have many different ways of doing it, but we have to decide if we want to take it through the scope or not. So we have the rat tooth forceps that we can use to take one by one through the scope, but not for 10 French steps, because it will block. And we have to take them one by one. The snare, it's a good solution. You can take them all at once, but you have to take out the endoscope. Even if you have difficulty getting there, maybe it's not what you want to do. And the surrender retriever, as I said, we use it to dilate, but it was initially designed to put the guide wire inside the stent and to screw it inside and to bring it back. It's not always smooth, and I don't think we use it very much for that indication. Huh? The dolphin, the thin part first, thin part first. And you can see it when you look at the stents that there's not exactly the same on both sides. The part that goes inside the bile duct is more aerodynamic, and it looks like a dolphin nose. We put the flap bended backwards to decrease the migration rate inside the duct. We, especially for the double pigtails, will check for if there's a distal marker. And if there's not, we'll add one with as a magic marker. We use a lot of this silicone spray that the anesthesiologists used to intubate. If you want to put multiple stents next side by side, we can also put it a bit on the stent before putting it in. The problem is that everything kind of like slips afterwards, so you shouldn't put it on the floor. And it makes it a bit more rigid, a bit like when you went in the endotracheal tube, you have the same effect. So it makes it a bit more rigid, and also that it's more smooth. So you can put them side by side in an easier fashion. So this is different examples. Here we have an hilum. We have 3 plastic stents in place, and then we will replace them if it's palliation, for example, here with metal stents. And this is an example of the plastic stent insertion with fusion. So here we have the system with the fusion. So we will insert the guide wire, but it comes out in the tip of the catheter, of the 2 centimeters afterwards. And then we will push in the catheter, but the guide wire stays fixed there. So it's a very, very, very rapid exchange system. We lock the guide wire in the left hand, we push down the catheter. So this is the catheter, the guide wire is advancing on the tip only, but we can see them side by side. Here we are pushing the stent. So we already did the maneuver of deconnecting and pushing the stents with the nurse giving tension on the guide wire and the plastic sheath inside. But you can see you still have your guide wire there next to it. And what we will do now, we'll just release it from the little 2 centimeters where it's holding it by pulling back the guide wire. And you see it's released, and now it's completely parallel to the first stent. We will release the stent, and we will adapt the position of the guide wire to be nicely inside. Yeah. And then we are ready for to put the next stent that we'll put now in a long position. The last one, yes. And here we will dilate before, just to be sure that there's not going to be any migration. Dilate beside. Here it's always the nightmare is when your stent is migrated inside. So usually it happens on Friday at 5 o'clock in the afternoon, where everybody wants to go home. So the same in Holland, yeah. So this is the second, the last that we will put in long. And the tips and tricks to avoid the migration is to be sure that you're not with the guide wire in the flap inside. Because then you will pull the flap in and you're blocked, so that everything is free, and that you're also not, you're as parallel as you can to the first stent to avoid the contact on a big surface with the stents, and then also to be sure that your flap on the outer side of the first replaced stent is outside, and and this is what we like seeing at the end, the wily eyes. There he is. So this is for the multiple stenting. And I think that we have also a video with the SEMS. This is the metal stents. There's many different models, and we will show them also. We have some here. So we will retract the stillet. We put it on a guide wire. With most of these metal stents, you will see that the guide wire goes out there, so you don't have a lot of, you cannot give a lot of force to help the physician push in the stent. There are some stents still that can be put in long, but they're not. We don't use them very often. We just use them if we really need a lot of force to go up. No, c'est Mickey. It's Fernandez. So we keep the guide wire in the left hand and push the stems in the scope. Yes, we have that. We also talk about the organization of the patient. We have a video. So this is the point of no return. This is important because when Leila will reach that point, we cannot bring back the stent inside the sheath. So this is very important with the position of her hands. We will see. We can see the stent. So it's the mesh is metal. It's on the yellow introduction. We also have fluoro to help us define that also on the X-ray. That's the it is distal part of the stent. And here the right hand is blocked and the left hand is bringing back. Décoiffé. I don't know how to translate that. We deploy, but I like décoiffé better. It's just really. So sometimes a bit difficult in the beginning, right, Leila? You needed to give it a bit of to open it up. And now we see this. We also see the point of no return on this fluoro, but we also see it on the handle. The nurse can follow it on the handle. It's important. She will say, "Okay, I'm reaching the point of no return." And also, there's the important manipulation of adjusting the stents, because when we do this, the stent goes upwards, so we have to bring it back. The operator has to bring it back to keep it at the same position, and he is guided by the mesh and the end of the stent, the markings inside, what he sees inside on the endoscopy. So here we're reaching the point of no return. We have a very good optical control as well, endoscopy, and then there's we pass the point of no return. This is the deployment. You see when it's the catheter is pushed back just to avoid that there is you misplace the stent by pulling back the catheter. So you bring it back to close it, and then we will take it out. Ça draine bien. Lots of bile coming out. Very satisfactory when we see this. And we bring it out there. So vision. This is very important because it's very important to know the endoscope. And this is also the young doctors don't really take this under consideration, but not everything can go in everything. And we have to know the scope. There's most duodenoscopes are 4.2 millimeters operating channel, but we have the smaller ones, the pediatric ones that have a different operating channel. And this is also very important here, the French and the millimeters. And I remember when I was a very young doctor, Sonia taught me that it's 3:2, right? Where is it? I saw it yesterday.
It's 3.
It's
1/4.
3.
The French 2 millimeters.
So the one French is 3 millimeters. Yes. So you have to know if you're talking in French or in millimeters or in inches. But usually the guide wires are in inches, but the devices are in millimeters or in French. But this is very important. All this information to know what you can put in your devices, how many guide wires you can put into your devices. If you can put a guide wire and something else, if you can put how many stents you can deploy at the same time, Here there is biopsy, forceps, balloon, and what's that? A catheter. Yeah. So this is this you have to manage to have this in your mind somewhere and read the packaging. So tips, stents are in French, the balloons are in millimeters. As we saw, the dilation, the flaps can finally be a bit more, give a bit more larger than the French, the French that it's supposed to be. And also the elevators and lateral viewing scope can give a little difficulty in handling the devices through the scope. For example, clips, you know, the clips, deploying clips with the lateral viewing scope and elevators can be sometimes tricky. So US, we have radial linear forward view. We will do radial is just for diagnostics, and our punctures and our drainages are what we do with mostly the linear and sometimes the forward view. The radial will give you this really easy to interpret image with the different layers, but the linear is the one that will give you the possibility to not only do diagnostics, but also to drain. And the forward view is if you want to go in a different direction because you're linear, you're in the lateral viewing direction. It's also very interesting to see the different needles that we have. For example, for the axis needle is a needle that you want, if you want to do, for example, therapeutic procedure, if you want to do a pancreatical gastrostomy, you have a stylet, which is beveled, which means that it's in this kind of form, as you see here, the first image, but the needle is straight. So you can go puncture, get into the duct, but if you want to manipulate the guide wire, then you take your stylet out and you just need the needle. And this is important because you will, if you have a straight needle, you will not traumatize the guide wire. But if you have a beveled stricture inside, you might peel it and then you won't be able to work anymore. So this is the importance of the axis needle if you want to do therapeutics. If you want to do FNA, FNB, you have different designs. So it's the stylet is straight and the needle is beveled. And the FNB, it's the needles have a little tripod at the end. You don't see it very well here, but it's important to have good carrots. So most now for the solid lesions, we'll use FNB. For the cystic lesions, if you want to aspirate, you will use a 19 or a 22 gauge FNA. And then you have the special needles, Giovannini needles for the celiac bug. We have lateral openings, so the product, the medication could go in both directions. So X-ray also very important. So we are very lucky to have technicians already working with us that take care of all these. About well, if we have to do an ERCP in the patient that's pregnant, we will have to do it, but we'll be very careful to go to ALARA as low as reasonably achievable. We also are careful about allergy and contrast. We can do an ERCP if patient has allergy to contrast, but you cannot do a percutaneous procedure because you might inject the blood vessels. We offer protection for, I talked about pregnancy, but in everybody that's still can procreate, give birth, and also to all individuals in the room. So everybody has protective clothing. We like and the control. Oh yeah, and the measurement of the X-ray. We check all imaging with the team before the procedure. If it's a ERCP, we look at which duct we will want to drain, a bit the anatomy. If it's a cyst we want to drain, we saw the MRI or the CT scan. So it's very important as nurses to ask to see the images before, if your doctors don't show them to you. And you establish a plan. So you said, okay, doc, what we're going to do. And you have the plan and you prepare your material according to that. And the X-ray is there ready to guide you throughout the procedure. You can use many anatomical landmarks like the vertebra for measurements and also to be sure of what you're looking for. If you want to put a stent, for example, in the esophagus, you can use either the anatomical landmarks, either you can put the metal marker on the needle, either you can inject lipiodol, which is the landmark that will not move at all. But if the patient is under anesthesia, you can take an anatomical landmark or the metal marker. So we try to keep the door closed when we use X-ray, but it never works in our department. Everybody comes in and out, but it's very important to keep the door closed. And I was in Cluj-Napoca, the X-ray stops if you open the door. It's a good way to prevent. Yeah. So cytology. So this is the importance of tissue acquisition. So we have the brush that we use. We can use them on a guide wire. And this is very interesting because, of course, you can you have already done your ERCP, you have your cholangiogram, you see where your stricture is, so you can really put it where you want to brush. You have the tip that's visible, then you you push out the brush, and you do the movements to go in and out without going inside the sheath. But when you finish, you pull back the brush in the sheath, and then this is important to get the maximum of your tissue. You will move it in, but also take the whole brush, cut the whole brush to give it to the pathologist, so you don't lose anything. No, you have to have a good go to Bricot and buy one of these that cut well.
Yeah.
So this you'll see this will be more difficult because we made this video some years later, and it's the same device, but it works less well. So we have to buy a new one.
We did.
But we managed, we did, but okay, that's good. Yeah, it was starting to become a bit tired. So there we are with the whole device, and this will be sent to the pathologist. We don't, it's our pathologists that do that. Yeah, we don't do the brushings like that, but then some centers, of course, they do it. Also for the US guided FNA, FNB. So here, this is one example of an FNB needle. You have a sheath adjusting ring and the needle adjusting ring that you can use to take a bit out your plastic sheath. And then the other knob is to release the needle. So we prepare a vacuum pressure syringe like that. We bring back the air when it's closed. So you have vacuum already inside. The puncture, once the lesion is punctured, we will take out the stylet. And we'll put the syringe on top. Open it. We're in the lesion now, so we can go back and forth to bring in the tissue. We always check the needle to be sure that we don't have any liquid coming up, blood or bile or something abnormal. Yes, so when we finish, we close the syringe, we remove, close the needle, pull in the needle, remove it. And this is to extract the carrots. So we reinsert the stylet to push out the tissue. And here we show it with two operators. We see this good tissue acquisition. And now we'll also show it how to do it if you're by yourself. So two hands, not 4 hands, only 1 pair of hands. So the loop, as you saw here, pushing in the guide wire, and you have a system to put the little, make a little hole in the carton there, and to so nobody has to hold it. Good trick, huh?
Yeah.
And then we bring back the needle, and it's ready also to go to the pathologist. So this is the therapeutic, so it's getting transmural drainage. So here, as I said, we always see the videos before. This is the collection in the hand of the pancreas. And we see it, it's nice, nicely positioned there from the bulb. It's not a lot of debris, so it's nice blob of liquids. So we will do cystobulbostomy. So this is a cystotome. You have a port for the needle on top and a port for the cystotome. And this is important in the sequencer that you're going to use. So after being well identifying the structure, we will go inside with the needle, and you'll see the use of the cystotome for the needle. We'll aspirate the liquid. You push the operator will push first the pedal for the current and then push in the needle. Here we put the guide wire inside and we will loop it. And now we will extract we will leave the cystotome in place and the guide wire, of course, and extract no, first we put the cystotome, yes, sorry. So we push the cystotome inside, then we will take out the sheath, and then we put the second guide wire. This is in the idea of putting 2 double pigtail stents or a catheter and a pigtail stent. Here we will dilate over the guide wire. We can also put first a stent and then dilate. Yes, so this is the pigtail. So we put a mark in this one because there's no marker. But now the new stents have also a second marker, but it's very useful for if there's not one to seal this, because you cannot really see the end of the pigtail stent. And if you see it, it's too late. So this is the operator, of course, will take all the precautions to also prevent migration. And then push the second stent again. We have one stent in place, so we're a bit more comfortable after during this maneuver. But the first one to put the first stent is a bit stressful. So adverse events. When things can go wrong, they can go very wrong. So this is during ERCP, bleeding, perforation, infection. How can we prevent it? So we know the NSAIDs, rectal NSAIDs, we give it to almost everybody in ERCP unless they have chronic pancreatitis. Even then, I think that it's a good rule of thumb to say we give it to everybody. If there's contraindications, of course. IV, you can hydrate with ringers, lactate ringers, which is Hartmann. And we can also put a prophylactic pancreatic stent if we have done a double guide wire technique and there's a guide wire in the pancreas. If not, you're not supposed to start looking for the pancreatic orifice. It's better just to put some perfusion and the NSAID. So infection, there's some cases we give prophylactic antibiotics if there's a complicated ileal stricture, for example, that you're not going to be draining everything from the beginning, or if the patient is fragile, previous liver transplant patient, etc. Bleeding is, if it bleeds, then you have ways of managing this by coagulation. You can simply use the tip, the wire of the sphincterotome to coagulate. You will try to be aware for the pancreatic orifice. You can use clips. Clips might be a bit challenging to deploy with the lateral scope. Injection of adrenaline and fully covered stems. Yes, I put 2 times clip to show how difficult it is, but it's fully covered stems can be a very useful technique if nothing works. And the balloon as well. So you can inflate the extraction balloon and just put it there, do a bit of tamponade. You can start by that before doing all the other stuff. Yeah, you can, if there, you can clearly see that it's on the sphincterotome, the edge of the sphincterotome. You can use your sphincterotome and coagulate, but the balloon tamponade is a good trick. And perforation is really identifying the landmarks of the papilla, not going too far away on the duodenal wall, being, of course, gentle. If it happens, fully covered stems, and really assure the drainage of the duct with antibiotics, we have a good chance that if it's a perforation around the sphincterotomy, that we will manage. If for the perforations in the bulb, for example, that will have to be closed with clips. So we have a lot of things in the toolbox, not only for OCV, but for other things as well. So adrenaline for bleeding, and if it's for bleeding also, we're not going to use it monotherapy, but a bit if you have a bleeding during ERCP, during sphincterotomy, you can manage it also with a little bit of adrenaline. Hemospray, clips, we have through the scope clips. We also have the OTC clips. Endoloop, this is for resecting pediculated polyps. We have a little video afterwards. We have coag-grasper and bipolar. We're done with your electrocoagulation unit. The tamponade with the balloon, as we said, and always try to drain if you have perforation or bleeding with a catheter, nasobiliary catheter, or a stent. So this is the endoloop. This is really your moment. So this is when the loop is inside, and with a yellow tube, you can bring it inside, outside. You position over the target tissue. You bring the slider back to ligate it. And then you have, once you have the little plastic thing in place, you can release it. So the loop here is around the stalk. This is a big polyp. Yeah, pediculated polyp. Now you're bringing back the slider to ligate. And we will see if you see through. We wait for the little plastic thing to come really onto in contact with the tissue.
Yeah.
And we wait.
We call it ABBA.
Yeah, I have it. Yes,
also-
I have it afterwards. The ABBA. Yeah, it's arriving.
Yeah,
We see it
see it.
finally there. And then he will release it. So detachment with the slider, pushing the slider, it's detached. So now it's released as it's supposed to be. And now the operator will take a snare and cut above the envelope, above, very important to cut above. So now he has enough stock upstream the loop to close it without taking any adenomatous tissue. Yeah, very good. And now you can already see that the polyp has changed color. He's been strangulating, blended current, and then it's pretty effective because we don't see any blood at all. And we will finish by retrieving the polyp with the snare. And I have the ABBA at the end. So it's advance, bring back, that's to open, that's to ligate, bring back, and then advance to deploy, to release. So we almost at the end of the PowerPoint. So these are the 10 commandments. Never alone. There is a team, organization, and order. Communication, verbal and non-verbal. Air is our enemy. Preparing our material. Again, communication, verbal, non-verbal. So it's so important. It's twice. Not on and off. We showed that with the sphincterotome. The procedure is over only when the patient leaves the room. Be gentle. You always have your teddy bear with you, and you will see which one is that. And your best asset is your hands. So always team, it's a teamwork ERCP, and that's why it's very important to train your doctors to show you the images, tell you what they're going to do, and to work in a team. We are quite lucky to have a good team, and we also have an anesthesiologist. We also have a technician for X-ray, and so this is the best conditions possible to work. Organization order in the room to know where everything is. I have a labeling. I think we have a little video for that. Yeah, organizing your environment. So it's labeling can help keeping things in the same place and knowing what you're looking for. You can use little tricks to label your guide wires. And it's you keep them looped to have a little bit of visibility, because when your working table is like this, it's a bit difficult to, so we have to get better. So a little bit of magic. And things seem to be getting better. So you get rid of everything you don't need, the big boxes, everything can go underneath. You keep everything loops on the right, on the left side. I've learned that the water is on the right side, but you know really how to organize your table, and it can help you. It can really decrease the time of a procedure. So communication, it's important to really be clear in what you're asking on the doctor side and also on the nurse's side. It was also important in training. We saw that, so you really have to have the same expressions to say what you're going to do with a small wheel, what you're going to do with a big wheel. This is very important to get the message passed. Yes, and also, so both people may have their opinion on something. You can discuss and see what's better to do, and then take a final decision. But this is mostly to say that you have to be very clear in what you say, because sometimes we can understand something different. So this is the non-verbal. We say a lot of things with the body language, with our voice, and finally much less with words. But this also has to be quite clear, and we have to listen, because most of the time our eyes are on the screen, so we cannot always see the expression. So we have to be very clear in what we express. So preparing our material, take out everything that's unnecessary. We flush with contrast or with water according to what we need. The guide wires in water and flush. The torque to be ready. We try to work without loops. You saw the force transmission, not on off. You have a lot of degrees of directions of liberty when you know how to use this not off on off possibility. Air is our enemy most of the time anyway. We also use CO2 nowadays, and we try to avoid sufflating too much, because we might have instability. This is also for the young doctors. It's important to have less air as possible, because it might be a difficult differentiating between stone and air bubbles. A procedure is over only when the patient leaves the room, so we know. Always be gentle. And this is very important to have the teddy bear is the gauze, the the gauze with water, which is important, putting water on all the devices to make it to clean, and also to make it hydrophile and to make the exchange easier. And of course, the only way to do a great work is to love what you do. Your best asset is use your hands. We saw the amazing combination of what you can do with 10 hands in your tummy. This is the 14 needs, basic needs of any human being, also for the patient. And this is important because we don't do a procedure, we take care of a patient always. And so this is all the things that we have to be careful about when we position a patient for general anesthesia, for example, is the positioning of the head. We have all these different boxes, balloon, how do you call these? Yeah, pillows to have the best position for the neck. Different types, so we have to see. Yes, if it's on the side or it's on the is in the supine position, this is for the side, better for the side. We have to take care that there is no compression. If a patient has even 1 hour anesthesia, he can have compression on his hands. So we take care that his hands also are protected, his feet as well, as we see here. We will also take care of the temperature of the room. You will see here, we put a blanket. Sometimes we have to put also a thermal blanket to keep the temperature stable. This is something also the anesthesiologist will ask. When the patient is arriving for the procedure, they're usually very scared. And the first thing that we do when we see them is to kind of reassure them. And if you're cold as well, it's probably, you're even more uncomfortable. So these are the basics to prepare somebody. He's still awake in this case, and it's very important to put him in a safe mode, and the rest, the procedure will go on well. So nurses are beautiful, we know that, and we love them too. So we can do some practice now. So I'll just maybe, as you prepare, Sonia, I will check. We can stay online maybe. I'll see if there's people connected, because I cannot see here. We can see if you have questions in French or in. Il y a des gens qui sont. There are people that are connected. Okay, we have 2 people connected, so we will keep them. Claudia Reis and Nelson Martins.
Nelson.
Ah, you know him.
Ah, yes.
You have any other questions? Okay. Oh, we had to rename myself. Yeah, okay. So if there's any French-speaking questions, maybe? Des questions en français?
Non.
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 On va peut-être trouver. Hein? Non, il n'y avait plus de questions là. Any questions?
I had a question about the
Yeah, the multiple stenting.
multiple stenting.
Okay,
How you do it? So we want to see.
Oh, we can show that.
Yes.
Yes.
Because maybe we can put some gloves because we have used.
Yes, yes,
Oh,
yes.
okay. Just put the-
Comme ça, je peux trouver. Hein. Oui, j'ai trouvé un bol.
Il y a aussi des compresses.
Ah, yeah.
Maybe we can turn the table maybe?
If we work.
You can turn the table with me. Just yes. So we can turn this way.
Ah, yeah, like this, yeah.
Mais ça c'est
Yeah, this is better. Ok, parfait.
La dernière, c'est en axial.
First stand, this one. And this one for pigtails.
Comment on dit indication?
Indication.
Yes. So you have flats,
Yeah.
but you have also the pigtail here.
Yeah.
It's the same indication, so it's to avoid the stand to move up of the.
Yeah.
Okay. This is so we. Are you going to?
Are you going to speak?
We have just,
One microphone, so when you speak without microphone.
the other people can hear you. I have the microphone, but I can give it to you. No.
Stay close.
Okay, I'll stay close to you. So,
And so if we put a stent for avoid the pancreatic, acute pancreatitis,
Yeah. Yeah.
so we cut the distal flap, or we buy one designed for that.
Yeah.
So for using the fusion system,
Yeah.
it's better to use a 8.5 French stent,
Yeah.
not the 10 French, because it's very hard to the duodenoscope.
Okay.
Well, this one is a 10 French, just to show you.
Yeah, okay.
Okay.
that's why it's here, because we don't use it.
Yeah.
So first you push your wire with the catheter
Yeah.
in
In
the
base,
bile duct.
yeah.
And so on push. So this this is the
I'm the bile duct.
no, this is the papilla.
Other papilla.
Okay. Okay. Then after that, don't forget to. Y a pas de contrôle? Ok, ça roule. You take your doodle. There, with water. Okay. So where is the stand? The straight down. Alors, always if you put multiple stands, always the longer first and the shorter after.
Okay. Yeah.
Okay, if you put the
First
short,
one and
if you
then
push the short,
Okay.
put by pushing the second one who was the long one,
Yeah.
you on dit,
Ça?
c'est-
Ça, c'est plus aussi.
you may push the first one into the.
Inside.
Okay.
Yeah. Yeah.
If
Yeah.
you put the longer one
Yeah,
first, it's, ça va aller, je sais la démo, hein, t'inquiète pas. Mais il rentre pas.
Ah, ok.
So you put the first and short one over
Yeah,
in the
Over there.
over the dinner sheet.
Yeah.
Okay.
Dolphin, huh?
Dolphin. And then you have a radiopac marker.
This
here.
is this
Yeah,
way.
the dolphin. Yeah. Yeah.
Yeah.
Yeah. we
You
found
see
it.
the radiopac marker there?
Yeah.
Yes. You go in and
Oh.
go out. Wait, where is the hole? You see it?
Yeah, it's difficult.
Help, Lala.
When in the room, it's dark.
It's easier in dark.
Yeah.
Yes.
There.
Yeah.
Je sais pas if you see it there. No, on montre pas
That's,
là.
yeah.
So it's passing here.
Yes.
Yeah. Yeah.
Okay. This is the endoscope.
Yeah.
The endoscope here.
Yeah.
It's going to the valve.
Yeah.
Okay. And then we push, the physician push the system alongside the wire.
So yeah, your this
pas de
is
gants, toi, je
no. Oui, je vais le mettre après.
Ok, je vais t'avancer ça comme ça. Hop,
Hop.
it's easier. So,
This is it goes inside the
Yeah,
bile duct
yeah,
like this, and I have the physician has it in his hands
push,
Yeah.
the
push,
thing
push.
separately.
Yeah.
Okay, so this is with the
This is the papilla.
the
here,
papilla.
Yeah.
And this is the stricture there.
Yeah.
Okay. So when we are here,
Yeah.
the physician is still pushing the inner the
Stand in.
The pusher.
yeah,
Yeah.
the pusher
Yes.
up to the. On va retirer ça.
Right.
Up to the
The
stricture.
stricture.
Okay.
Yeah.
And then to remove, tiens ça, to release.
Release. Yeah.
Okay.
That's
We have
important.
first to
Yeah.
come back the 2 centimeter in up to
Okay.
the black marker.
Yeah.
If you don't do that by releasing the inner sheet,
Yeah.
you will take the
Yeah,
the
that's
stand
it
back.
with you. Yeah.
Okay, vas-y, tire. If you do not release that,
Yeah.
you come back Donc, comme ça.
Okay, yeah, so,
Clac, clac,
yeah.
clac, and the stand is coming back.
Yeah, yeah.
Okay.
yeah, yeah.
If you. And there, on remet ça là. Hop, clique dessus. Hop. If you release the wire
2
there,
centimeters.
here,
Yeah,
so
It's
it's going to slip
yeah,
aside the inner sheet.
yeah.
Look,
There.
and
So
we
it's
push
now it's
back,
parallel.
we push back,
Oh,
and we can release the
And
first
now we
one.
can release the stand.
And,
so-
and this one
It's
is
still
ready.
inside.
It's still inside and ready for the other stand.
Yeah,
come out here.
it's just here, it's just,
Okay.
this is the only part that these two guys are together. It's the 10 centimeters, yeah,
We didn't know that.
yes.
We-
Like this,
We will repeat it.
On va le faire en
We will
français.
repeat it.
Mm.
So the wire. On va le remettre dedans là. And so it's very important to put the longer stand first.
Longer first.
Yes. So the guide wire is in the binder. On va le faire comme ça, il y a des points.
Oui.
Je me touche là.
Oui, ça dépend.
C'est bon. C'est bon. On y va, on retourne. Ok, tac, tac. L'histoire des flaps, ici, ils doivent pas expliquer ça. Hein.
Non,
Le sens des flaps,
non, tu les trouves
c'est dans l'autre sens, hein, parce qu'on a fait là.
Ah oui, oui, ça c'est, si on a rentré ça dans la voie biliaire, bravo.
Always
Hein.
work with the guideline, Okay, you go
Yeah.
here. Go out.
Pour
There.
les
It's 2
premières.
centimeters.
Yeah.
Just the black marker, radio marker. Okay. The second nurse is taking the wire.
I have this in the endoscope,
Okay.
and then I keep this with
Keep.
like this, and then I push down, tac, tac, tac. But so you end up seeing only the guide wire and this.
So you see, this one is very souple, flexible.
flexible.
So you
Yeah.
can push the end of the wire into, you remove
Yeah.
the stylet and push this one
to
up,
help you.
up to.
Yeah.
Pour la dernière, quand on passe
No, 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 no. See,
Okay.
the stylet here
Yeah.
is really flexible.
Yes.
Okay.
Yeah.
So it doesn't help. You, if you
doesn't
want to
help.
give some, a bit
You
of
can push the
rigidity
end.
here,
Oh, the end of
The
the.
end of the
okay.
wire.
just for rigidity.
For the rigidity
Oh,
up to the
Yes, sir.
Yeah,
before
yeah.
the hole here.
Yeah, yeah.
Otherwise, you will block
Yeah.
Yeah.
with
Ah, d'accord.
plus de rigidité.
It doesn't give any traction for me, but
No.
it gives a bit of
Yeah, stiffness.
stiffness, yeah.
Yeah.
Dans les différents, je ne vois pas, mais dans le 8,5, oui. Et comme
Ah,
on l'utilise plus
Donc
sur le
là, on
8,5,
est ici, we're here.
Yeah.
mais ça, c'est difficile de faire du rapid action, de fusion avec 10. C'est vraiment trop difficile. Sinon, on ne le fait plus. Et
Okay.
donc, on fait ça
And
avec
afterwards, when we have put the stent, push the stent inside, when we're ready, now we will
tendu, hein.
we'll just, the operator outside from the scope
Yeah.
will bring it back just to release the tip.
And you see on
You
the
see it on
scopy,
this, yeah.
Yes, with the
Tac,
screen.
tac, tac, there, so
Flaps,
it's released
tones.
there.
Okay.
We readapt et puis on release les trucs,
You may release the stand with the system, like the resist system.
like,
You release the
yes,
stand.
you can resist, yes, so now it's
Okay.
released. But of
Okay.
course, if you do this with the thing there,
Yeah.
it won't release.
No, 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 no.
Il va être bloqué.
Yeah.
Hein?
Par contre, c'est bien de ne pas le faire trop tôt parce que parfois la prothèse est trop courte ou trop longue et on sait la réenlever sur tout le
Oui,
système.
c'est
et
ça,
la
oui,
changer.
oui.
Donc, ça a des plus et des moins.
Diffusionner vraiment le faire à la fin.
À la fin. So we diffusion the thing at the end, because sometimes you can use this, if you want to bring back the stent, if your system is fused still, you can still bring back a bit the stent reposition,
Yeah.
which you cannot do once you've released everything.
And if the stent is too short or too
Yeah,
too long,
too long.
you can remove it and place another one.
Yeah.
Yeah.
Okay? So the diffusionner
Yeah.
to release the 2 centimeter, really just before
Releasing the
Yeah,
stent,
yeah,
when you're
yeah,
ready.
Just
Yeah.
before.
Yeah.
Communication.
Yeah.
Il est en place.
Always.
Always. Voilà. Very good. Yeah. Et la dernière,
Maybe we can use some metal stands, no? Metal stands. J'avais amené des.
Regarde un peu le look. On va voir tous les sortes parce qu'on a, elle
Ah
a dit
oui.
que c'était intéressant. Just want to explain.
Do you have the Torx?
So you know,
But it isn't necessary to take this out.
yes, because for the 8.5 French, this is very too.
Yeah, okay.
It doesn't help you, it's too
Yeah,
floppy.
okay.
Yeah,
But
This one is the
it's
10.
not necessary.
it's not necessary,
No,
no,
okay.
but you can put
But
the
it's
guide
not
wire
a-
back.
It doesn't help.
It
Doesn't
doesn't
help.
help this one.
Okay.
It's,
But this one,
yeah, it's
helps,
better.
yeah.
more
Yeah,
rigid.
yeah, yeah, yeah. Okay.
So if you want to have a talk with the wire, you have talk in the dans l'emballage.
In the packaging,
the
you have the
package,
Torx.
You put them. Some guys don't have torque. So if I put loops
Yeah.
like that, if I turn my loop, I'm talking the
Okay.
wire.
Yeah.
Yeah.
That's an interesting, yes.
Okay.
So you need to
Ah,
loop
we
with
yes.
the
can
wire.
set,
You have to look with the
And then
wire.
you can just turn your hand
Okay.
actually, and you will turn it.
It's for the same reason. For the same reason.
Yeah.
If we have two noses, if I will want to use the torque here,
Yeah.
if my assistant, my assistant
Yeah.
have a loop
Yeah.
here, I can't do it.
You can do
No.
it.
No,
Okay.
so always when you use the torque,
Yeah.
the
The end has to
Right.
be,
have to be
Open.
Open.
Yeah.
yeah.
Yeah. Yeah.
Alors, I show it with the loops, but if you put, on n'a pas de
Mais j'ai pas vu de Torx.
snare, attachage.
Mm.
And don't you use a locking device? No, never? Okay.
Because we have two hands,
Yeah,
10 fingers, but the doctor also.
Yeah.
And so if Diana has scope in her hands, she can put the wire.
Yeah, we saw that. Yeah.
So,
Yeah.
it's better than
Okay. Tell our doctors.
Yes.
Yeah, we have now. First thing I do is take out the locking device.
Yeah.
Oh, yeah, really?
Mais, tu sens mieux si tu l'as ou pas?
Yes,
Moi,
yes.
tu veux pas te fier un locking device parce que tu sais pas si tu glisses.
You
Faut
feel
dire que
better if you have it
hands.
in your hands and you feel that.
Le
Yeah.
locking
Yeah.
device, ça
Going
se
out
fait
or
sur les
inside.
doigts.
Yes, but that's the way that's the way I work. I block it with my hand. Maybe it's others have the experience with the locking device, but it's not. You can live without it. That's what I'm saying. Yeah. Yes. Yes. We can also put 3 or 4 guide wires in our hands, and then we have a. I feel that I have a better control, but it's also how you learn. So.
Yeah,
Yeah.
that's, yeah.
Donc ici, l'histoire des story of the flaps.
Yeah.
Before we had
Yeah.
such kind of pigtail stand.
Yeah.
The only
This
one, huh?
one-
Yeah.
This one was
No, huh?
here
Yeah.
and
Yeah.
straight there.
Yeah,
So this
yeah.
this part
The outside.
stay in the duodenum.
Yeah.
okay?
Yeah.
But if the stand is straight in
In
the
scope.
scope,
Yeah.
you can't identify where is the end of.
No.
Because you don't have the flap
Okay.
that you
No,
have in the
you
straight
don't
stand.
have
Yeah, yeah.
So you have to push the mark.
Yeah,
No,
we do that with,
no, we have
The marker on the
We
side.
have
We
all
have that one
that
as well,
one,
yeah.
Okay.
without a mark.
But if you don't have, you have to pull it
Yeah,
yourself.
yeah,
Okay?
no.
Because that's the most
then-
stressful
Yeah,
thing when
yeah.
you the pigtail when it's
Yeah,
like,
You
oh.
don't know where the end is.
Yeah.
And
Yeah.
always when you push stand like
Yeah.
that, before you open the flaps.
Yeah.
Because when
We
it's
don't
going
do that
out,
either.
it's going out of the package,
Yeah.
it's like that.
Yeah, we know.
And
Yeah.
if you put it like that,
Yeah.
Oh,
Okay.
it's not gonna stay
No, you-
inside because
you
it's,
put
of
it-
course.
or you
Oh,
open
okay.
the.
Yeah.
Okay.
I get it, yeah.
Ça, mais je sais pas s'ils utilisent, mais il faut les couper, hein, parce que ça
Yeah.
perfore. ça-
Yeah,
ça
yeah.
perfore.
I don't know what it is.
Yeah, we don't
It's
use
a
it
kind of
anymore.
an old-
It was an old stand, but
Yeah.
usually you have to check out, this is what she was saying, that you have to check out the duodenal extremity, because you might have to cut a bit to trim them,
Oh,
because this
okay.
is too long and
Yeah,
can
yeah,
be
yeah,
traumatic
yeah,
for the
yeah,
contralateral
yeah.
duodenum. Same for this.
Yeah.
Yeah.
So usually we cut it a bit like this.
Yeah,
Yeah.
yeah, yeah. Okay.
Trois quarts, hein.
When
Yeah.
are you using this technique, this story, in order to wire is to help the doctor to cannulate the papilla
It's to
better.
work together.
But,
It's to go in the right or the left.
For the meaning the torquing.
Yes.
The torquing is yes, to navigate inside the difficult stricture or to choose the good intrahepatic bile duct.
We have a problem actually sometimes with when trying to cannulate the right way.
Bile way.
Yes, but this is going to be like probably good for us because
Yes,
we can
yes.
just actually turn the.
Yes, you need an angle tipped guide wire for that. Yes, but it's mostly for either to navigate inside the stricture in the distal anatomy of the bile duct, and very good to choose the intrahepatic bile duct, and also to avoid the cystic duct. If you're always going to cystic duct, maybe the torque can help you go in the good direction.
And are the patients for the ERSP lying on their tummy or on their side?
It's on the back. We have general anesthesia intubated on the back, and sometimes we put them on the side. Yes, but in the Netherlands it's prone. Huh? It's on the tummy. Yeah.
Also, we have anesthesia, but
It's without intubation. It with propofol on the yes. Our anesthesiologists prefer to intubate on supine, and we can also turn them on the right. Yeah.
nice. Thank you.
What else can we? This is histotome. That's also useful. Alara, it's as low as reasonably achievable, meaning that we do not give any X-rays that are not useful.
C'est pas des photos de vacances.
C'est pas des photos de vacances. It's not vacation. Yes, it's not souvenirs. FNA, FNB. So FNA is yeah, maybe we can do a FNA is mostly for we used it for cytology for cells, but also to aspirate the liquids. The designs of the FNB needles are in a way that they give more tissue. Yeah, maybe we can show it here. Oh no, we don't. We have needles, huh? We have. I know, but for the FNB, what have we here? Well, this is the FNA, I think. Huh? Okay, I'll show the FNA here. So the FNA needles is just a simple design. Huh? It's just l'FNA, les types de l'FNA. Juste montrer l'FNA. Oui, juste pour la plus là. So this is the sheath. This is to bring out the needle. This is the needle. So that's the sheath outside. This is there's a stillet as well, and the needle. So it's very difficult to see, but I bring back the stillet. The needle is beveled, but it's just a little hole. There's no design on the needle. It's like this. Ah, this is not mine. This is yours? Maybe. So it's the needle is like this. It's just a hollow tube, sharp hollow tube, and the stillet is straight inside. So when you take out the stillet, it's like this. Yes, it's a hole. The FNB needles have a different design. They have a tip with 3 forks like this. And that's what gives more tissue. It's just the needle design. The end. Not anymore. No. With this system, we don't need a pathologist in the room anymore. Yes, FNB. Yes, this is an FNA needle, but with the FNB needle, we don't need a pathologist in the room.
We have a lot of instances in our because of the tissues we do from the it's very often we don't have enough tissue.
With FNB, either you do 3-4 passes with this, either you do 2 with FNB and you have more tissue. Yeah. Só pregar, é por isso que eu disse, Yes, yeah.
How much suction do you
The
use?
vacuum.
Ah, suction, combien on met de l'aspiration?
Because
Combien?
we saw it was 20.
20.
We only use 5.
Five.
Five
Or 3.
of 10.
No.
We know do a lot. Yeah.
We never did good actually.
Well, this might also bring more tissue, the aspiration. So now we don't always do aspiration. It's not the first step, but if it's a you're afraid that the lesion will bleed, then we might just do put the needle in, put slow, still it. Yeah. This is slow pull is when you're afraid that it's going to need the thing is going to bleed.
Yeah.
The lesion is going to bleed, but usually for solid adenocarcinoma pancreatic, we do.
We
Right
don't
here.
use many suction, but when we use suction, it's all.
Yeah, pneumologist is shorter. For the pneumologist is shorter. For the standard punctures, we use 20.
Okay, and for the lung, we use 5.
5.
Five.
Yeah.
For the gastroenterology, actually 10.
Yeah,
8, 10.
Yeah. Okay.
You have two systems, FNA and FNB.
This is the FNA. This is the FNA, and it's really the needle that changes, the design, the tip.
Yeah.
The needle for the FNA is just a hollow kind of metal. You bring out some cytology, but not carrots. The difference with the FNB needles is that the design is different. The tip is 3 tips,
Yeah.
and it gives you carrot. A bit like the needle for the liver. It's the same design. So it's just the only thing that changes is the tip.
The tip. Okay.
Yeah.
Do you use that a lot?
Yes. All our punctures with solid is with FNB. Yeah.
We got 2 types of needles, the Procore and the Ultra. I think the needle form is different.
Yes, the Procore is the FNB, but we don't use the Procore anymore.
Okay.
We use the new generations FNBs, which is the Boston Acquire, the Shark, Medtronic, and Microtech also has a
New generation.
yes. The Procore is a bit
Old school.
it's an older needle.
Okay.
Yeah.
Good to know.
Yeah.
Thank you very much.
And I don't know if you want to, we also have the, you want to see,
The Rolflex, yeah. Of course. We do that.
maybe, maybe this is for the girls. Vous voulez pas peut-être montrer un peu une prothèse là?
On fait la cysto, je sais pas si on fait
Ah oui.
cysto, tout ça. Tu le mets là.
They will doing the cysto, and then we'll do this if you want.
L'autre, pour le Boston, il est blanc, oui, avec la boucle, la pince, si on veut. Il y a différentes façons de le faire. L'escargot, si tu dois faire par demi ou café. Alors, on va faire le système.
We'll just do the cystotome again because it's important, and then we can do this thing.
Ça, c'est ton...
C'est mon kyste.
C'est ton kit?
Je sais pas. Oh là là, il y a de l'eau, hein, Sonia?
Il y a de quoi drainer là. Voilà. Wet shoes.
The cystotome. So explain it in English. Okay. So passing through this, the cyst. We see on the
Echo.
yes, okay. To the scope, okay. Just in front of the cyst. Yeah. Okay. We put
Current on the good port
Yeah.
not this one.
because endoscope kaput.
This is in the scope. Okay. If you put
Needle
current here,
white.
No,
Puff.
that's
Puff.
so we put
And the boss
current
is,
there,
Yeah.
passing into
I apply the current. I
Yeah,
push.
yeah.
First, I put the current on the needle. Then I push
the blue or the yellow?
the yellow.
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 Okay.
It's
you test Marianne.
I had a discussion with our doctor, so I want to know if I had it.
so
right.
pure cut effect
this is-
5.
So
So 20. So 120 watts.
Yeah.
is here
For
just
ERB.
for the demonstration. We have a loop, but
No, yeah.
okay.
We
No
understand
loop.
that.
Yeah.
Never
No.
have a loop.
When we are in the cyst, we remove the inner.
Yeah.
You still it?
We can push. Then it's a needle, huh?
Yeah.
Okay. Is it in an aiguille?
Like a needle,
Yeah.
You aspirate
Yeah.
the liquid,
the liquid
Yeah.
going to the anapathologist.
pathologist or the
Sometimes,
chemistry culture.
Do you use contrast?
Yeah,
sometimes
sometimes,
yes.
yeah.
Of course.
But with the guide wire, we have a good
Yeah.
So
loop.
we
Okay, so you see,
we will do a lot of
Yeah.
loops.
Times if possible.
Yeah, we
Loops.
yeah, it says it's in the peritoneum.
normally it stay in the okay. So
Ah, that's a
when
nice
it's,
loop.
it's
Yeah,
secure.
Very
Okay.
nice loop.
We will disconnect it.
It's a
Yeah,
nice
The
cyst
inner
model.
and the outer sheath,
Yeah.
and the physician will push
The
the
cystotome.
cystotome
Inside.
to the mucose.
Yeah.
Okay, and
And then now we
Yeah,
put
we put
we're ready. I put the current and I push, and I'm inside with the cystotome.
And watch
Toujours le
which
voir,
Oh, yellow.
Yellow.
Yeah.
No,
Now this
if
is
we
the
only
exchange.
have to put one stent,
Yeah.
we can remove all the system.
Yeah.
If we want to put two stents or a catheter and a stent,
Yeah.
we have to doubler,
Double the guide wire.
double
Yeah,
the guide.
yeah.
Okay. Therefore, we have to push the guide wire and to remove the inner sheet, the white one. Okay.
Mhm.
Push the wire, please. Yep. Okay. And in this big catheter, we can
Yeah.
place the second wire.
Yeah.
Yes.
Only two.
Or three.
Three?
Yes.
Yeah, that is.
O 20.
Oh,
It's O 20 35. This one.
okay, yeah.
Yeah.
Okay.
So you can put.
If you use the 8.5 cystotome, you
Yeah.
can push two O 25
Whoa.
guide wire.
Yeah.
each.
But 230.
Pour mettre une deuxième prothèse ou un guide un gâté une prothèse. Si tu dois mettre une prothèse, tu mets couche de perfection. Tu mets tes deux guides avant. À l'intérieur de celui-là pour les dédoubler. Si tu mets une prothèse là-dessus, en la larguant, tu vas perdre l'accès à ton kyste.
Ah ouais.
Pour mettre la deuxième, parfois ça va, mais il faut compter sur la chance. Donc, pour ne pas devoir compter sur la chance, autant prendre la sécurité.
Oui, parce que mettre une deuxième récathétérisée après un truc qu'on vient de faire, pas trop.
Il y avait un autre.
Too much use.
Il y avait un autre. C'est bon?
No. They had a long life, these
Yeah.
instruments. That's a lot of
Not
people.
this one, but the wires.
Mm.
So we put the second one
The way
and
it
make some
follows the same,
the same.
Oh,
When it's secure there, we can remove the big.
Yeah.
the big Bertha, we call
Lala
her.
is pushing the two wires there.
Yeah.
Look.
Yeah.
Okay. At the same time.
Yeah.
Okay. When you are out of the scope, you can remove
Yeah.
it
Yeah.
this way. And then we have a wire ready for a stand and the other one for the.
Yeah.
Okay.
And usually they're all mounted already. One of the, when we work on one wire, they're already preparing the second wire.
Yeah.
Alors, the question is, why not to put only one guide wire and use the fusion system to put two stands? Why? Because with the pigtail stance, it's very difficult to use this fusion system because of the curve. It's difficult to release
The guide wire inside. If you release it, everything goes, the pigtail is formed and.
Oh, okay, yeah. Otherwise you can
No.
Otherwise,
Yeah.
if you want to push a straight stand, then you can use the fusion system. And you don't have to double the.
Okay.
Okay.
I will. One thing on the balloon, the dilation balloon.
Yeah.
Les petites prothèses, peut-être faire une petite prothèse métallique.
Vas-y alors.
Sister Tom. Oh yeah, it's not for human use. It's finished, finito.
Qui voulait voir, who wants to see this one? You? Non? Qui voulait voir celle-là? Je pense que c'est les...
You want to see the wall flex? Yeah. Okay. So this is a enteral stent, but it's a bit the same kind of release that we did for the result for the biliary. So we also put this on a guide wire, but a thick, a stiff guide wire, and once we are in place, so so here this is very important for the physician. This is you do under X-ray, but you can also do with endoscope control. So this is the end of the stent, and you see, and this yellow marker is like in the biliary stent, is the same thing. You have the yellow marker there.
Yeah.
Okay, so do we have to do anything with this part here? No, this part we don't have to do anything with this part.
No.
Okay, so we introduce. We're in the stricture, like this will do it. So you can show the hands. So right hand fixed, and she comes back. She comes back, and now you see, you see that when we do this, the stent advances. So I have to pull it back. I have to pull it back to replace it. And we continue doing this. On peut ne pas le larguer. So you have, this is the non, so we're going to go until there. We're not going to release it so we can keep it again. But this is the most important part for you, the movement. Right? Yeah. And then when when we go until there, we can still come back and recapture the stents. Okay, same.
Thank you.
En plate, oui.
Maintenant, ça n'existe
Mm.
plus. Ça varie.
Ça varie, yeah.
C'est pas possible qu'il peut aussi apprendre le français un petit peu.
Mais
Avec le ça varie.
vous parlez français là?
On doit pas obligatoirement. Non, pas obligatoirement.
Non. Ouais.
Ouais, c'est ça. Plus c'est rigide, au mieux c'est. Ah
oui. Oui.
Ah oui.
Oui.
Si c'est vraiment sténosé, vous nous prendre.
Mais si c'est une sténose difficile, là on va prendre plutôt un JAG. Un JAG. Mais si tu n'as pas vraiment de sténose, mais tu as un sleeve où tu dois aller plus loin et là tu as besoin de quelque chose de plus rigide, on va peut-être prendre quelque chose de rigide. Oui. Mais sténose œsophagienne, on va prendre un JAG par exemple, c'est tout droit.
Ouais. Ok.
Mais on va peut-être les garder tout ça pour. Ouais, hein. Quelle heure il est?
C'est bien des ateliers comme ça.
Ah ben, c'est bien, 4 heures, je pense qu'ils sont. Ça va? Vous travaillez à Charleroi, ça?
Oui, c'est
voilà.
ça. Voilà.
Avec Manu, avec Paris.
Non, Manu, avec Manu, oui, bien sûr.
Paris, c'est parti.
Paris, c'est parti.
Oui.
C'est triste.
Oui, sympa. We're good, huh? Yes, we can stop. Yeah, we can cut.
Il va revenir. Ah, zut alors.
Oui.
Il est venu juste ce matin.
Oui.
Ok, ouais. Mais il revient, je pense.
Yes.
I unless you use the extension tube